Can you tell me your name and a little bit about what you do?
My name is Jamie, and I take care of my family. Um, in this village, I work for the community under YKHC. Um, I take care of a disabled client, and I enjoy what I do.
So, what has your experience with access to dental care been like in this village?
Since we don't have dental people coming in, they used to come here a lot.
How often would you see a dentist like before COVID?
Every 6 months to a year. Every time they come here.
How about during COVID?
It's getting harder because we have to travel to Bethel to get our teeth checked.
How easy is it for you to get to Bethel? Is it easy or challenging?
It's challenging.
Ever since I first came to YKHC, dental disease has been a huge problem for our youth. Actually, it's a problem for everybody, but especially for our children who have almost unregulated exposure to sugar sweetened drinks and candy. And we just were never able to keep up with the demand for treating cavities and oral health disease.
Alaska has the largest land area in the United States, but it is also one of the least populated states, with approximately half of the population living in the Anchorage metropolitan area. Alaska has the highest percentage of Native Americans in the United States, with Indigenous people making up over 20% of the state's population.
Life in the YK Delta is not the same as it has always been. One of the biggest changes is what children drink and eat. Elders in your community might have told you, in the past, Yupik people never got cavities. In fact, research from the early 1900s showed that people in the YK had no cavities. This is because the traditional Yupik diet doesn't have much sugar.
Any of these processed sugars that came with westernization to the region. So we've got 2 or 3 generations now that have been exposed to sugar, and the dental status really shows that it's really hurt people.
We didn't have primary care readily available in the villages, so people ended up with a lot of decay and a lot of needs for extractions.
I actually started providing dental care in the YK Delta in Alaska Native communities. And I spent many trips providing dental care to children and teenagers. These are really remote communities without a lot of easy access to dentists. My name is Donald Chi. I'm a professor at the University of Washington. I'm a pediatric dentist, and I also do public health research here at the University of Washington.
Some of you may know I started off as a dentist, a part-time dentist here back in 2012. And one of the things we noticed was some of the challenges families were having with the drinks that you were giving your kids.
What I was really interested in dentistry is that prevention was possible.
Nobody really likes having to go to the dentist to get work done, especially when it means having to fly from the village to Bethel or even Anchorage. It's not always practical and certainly not cheap.
Biggest difficulty for everybody accessing any kind of healthcare from Yukon-Kuskokwim Health Corporation is travel. We cover a region the size of the state of Washington or Oregon. We compare it to those frequently. We have 48 villages, not connected by road. All travel is by single or two-engine aircraft. And the biggest hindrance to obtaining medical care is the cost of flying.
Bethel is serving a lot of communities, a lot of people from all over the surrounding villages, lots, and they always have no room, unless it's an emergency.
We try to keep everybody enrolled and medicate as many people as we can because that will cover the cost of travel for people coming in for medical care. But that's an ongoing problem constantly. People will sit with bad teeth for months and years just because they can't afford to get into Bethel. We send out dentists to all of our villages on a cycling basis. We have to send out several hundred pounds of gear with them when they go out to the villages. With our newer clinics over the years, we've started making dental clinics with chairs and equipment built into the clinic, so that's eased that problem a little bit. But there's just a huge demand for dental care, and until we get ahead of children developing caries just all the time, we'll never really make a dent. We're just always just fixing teeth rather than doing preventive efforts like we would like to be doing.
When I came into the project, there had already been several years of work done into researching what exactly it is that kids here in the YK eat, and more importantly, what they drink and how much sugar they're drinking.
During these trips, I got to talk to families about the struggles that they were having with trying to prevent cavities in their kids.
And one of the big factors that leads to tooth decay in vulnerable and minoritized communities is sugar, particularly sugar from fruit drinks like Tang and Kool-Aid.
So we wanted to find a way to give your kids healthier drinks. And so this is where the sugar-free Kool-Aid comes into place.
We held community meetings to start piecing together a program aimed at addressing these fruit drinks. We eventually got funding from NIH to do our study, which would help families learn about the effects of sugared fruit drinks and healthier beverages that they could give their kids to prevent tooth decay.
These days, when you go to the store, you may see there are many choices for your child. Most parents know that soda pop contains a lot of sugar, and many think drinks like Tang and Kool-Aid are healthier. Parents also buy Tang and Kool-Aid because these are drinks they remember from when they were growing up.
So what we're trying to do with our program is that we're trying to help families change a behavior. So drinking fruit drinks is a behavior. And so behaviors are really simple to identify, but they're much harder to change. Now, beyond the behaviors, we also know that one's social context, the place where you live, the stores that you have access to, poverty, stress, low bandwidth, all those other factors can either constrain or they can help families make better decisions.
The most compelling aspect of our program is its ability to address behaviors without relying on the dental care system. It empowers families to take control of a significant risk factor for tooth decay that currently dental offices can't tackle: sugar intake. Even with millions of dentists, the current dental care system is not equipped to help patients modify their sugar intake.
How much do rest of the people in your household eat traditional Alaska Native food?
Every day.
Every day.
The first time we came out to the YK, it was a really awesome, eye-opening experience just to see beautiful culture that people have here and the way that they are so intent on preserving their way of life and the traditions.
As a parent, you know that the lessons you teach and stories you tell your child when they are very young will stay with them for a lifetime. The health of your child's baby teeth affects the health of their permanent teeth. If your child's baby teeth become infected with cavities, this infection can get into the permanent teeth even before you can see the new teeth and cause cavities there too.
They've gotten so accustomed to helicopter research out here where the person just comes once, conducts their research, and maybe never comes back again. Until you get that kind of traction where they know you, they recognize you, they have trust in you, research is never very beneficial out here.
So why do you think it's bad?
Because it's Kool-Aid. It has lots of sugar.
It has lots of sugar, yes, exactly.
What is really unique about the approach that we've taken in Alaska is that we recognize how complicated the situation is. We know that there are a lot of different factors that go into why it is families choose to give their kids sugared fruit drinks. We also know that the solutions in terms of addressing sugared fruit drink intake are also complex. And so the complexity of both the problem and the solution really requires an interdisciplinary approach. And what that means is obviously our team has a dentist and has oral health expertise, but we really rely on our collaborators from outside of dentistry to help us build the intervention.
We had collaborators from a variety of diverse fields, including dentistry, psychology, public health, microbiology, statistics, and sociology, each of whom contributed their specialized knowledge. We also collaborated closely with the Yukon-Kuskokwim Health Corporation, as well as tribal councils in the local communities who provided crucial cultural and local insights. On the ground, local health aides, community health workers, and schools were vital to our efforts. Local stores and wholesale suppliers supported our logistical needs, ensuring that families had the sugar-free drinks to make the program a success. Finally, Booster Shot Media helped our team make whiteboard videos used by the community health workers to educate families about sugary drinks and what they can do to make healthier decisions for their children. Together, this collaborative framework helped our team develop a program that empowered families to make healthier beverage decisions for their children and communities.
I am Cameron Randall. I am a clinical psychologist, and I do research related to oral health. And I've been working on this project since its very early days. We were meeting with the community members to help create this intervention and tailor this intervention to the communities. And we wanted to make sure that the intervention was really specific to these communities where we're working, and that it was tailored and culturally appropriate and really just relevant to the people who would be using the intervention and participating in the study.
So we worked in 3 communities in the YK Delta. 2 of the communities got our program, and the 3rd community got the program later. And what we did was we did the program over the course of 6 months, and we collected data all along the way to figure out, did the 2 communities who got the program, did the kids consume less added sugar?
Parents and children let the researchers snip a few hairs from the back of each child's head. The scientists then ran a special test that can use just a few pieces of hair to find out how much sugar a child eats in a day. Many parents were surprised to learn children were drinking and eating more than 50 teaspoons of sugar a day.
We decided that it was really important that someone from the community deliver the intervention. And the reason why that's important, especially in Alaska Native communities, is that when your interventionists look and speak the same language as your target families, that helps to build trust, and it really helps with delivery of the intervention.
As a clinical psychologist, I bring some expertise related to behavior change intervention, how to train our community health workers in good communication and counseling skills. I met with them and taught them about oral health and about cavities and about diet and oral health behaviors. And we also taught them about counseling and how to ask questions, how to get parents and other caregivers thinking about making changes for their kids, and then how to solve problems if they encountered problems in making these behavioral changes. Our community health workers met with the participants 9 times. They had 5 visits with the families as part of the initial phase of the program, where they showed them the educational materials, taught them how to mix the sugar-free drinks, and then checked in to see how things were going and to solve any problems that might have came up as they made the switch from the sugary drinks to the sugar-free drinks. And then they had 4 check-ins, sometimes in person, sometimes over the phone, with the families just to see how things were going over the long term. At the same time, our study team was meeting with the families to collect data to see if the program works and to see how well it works. And so the study team and the community health workers were having lots of contact over a full year with the families.
One of the things I want to thank you all for is we did interviews with you. You may remember back in, it would have been March, and in September, we did interviews to ask how you felt about the program. And we were able to take that feedback and actually incorporate that for families in our control group So we have we had 3 communities altogether, and one of the communities did not get the program from the start, but they just got it in September. So based on your feedback, what we did was we cut down on the number of study visits. We also made some of the program remote. So we did some of the programming via phone and via Zoom. And we also made the store piece easier.
So our program changed a lot. So we got feedback from families, and that's a central part of the approach that we take when working in Alaska Native communities. It's a community-based participatory research approach where we want feedback from the community.
We were ready to launch the program in 2020, but because of COVID, we had to wait until September of 2022.
The dedicated team has had many delays because of the COVID-19 pandemic and the various weather and travel delays that occur when needing to travel to these communities.
And of course, we all know what happened in March of 2020 is that COVID happened and the shutdowns happened. And so we had to end up postponing the program a couple of years.
Dental care was a little more irregular during COVID with the difficulties of having YKHC come out. You may also remember we had a lot of data collection. So this is where you had to fill out the surveys. We took hair samples and the plaque samples. We also did interviews the last 2 visits.
Good? Good. That's great. So it seems like they like it.
Yeah.
Hopefully that will make the switch easy.
So what we found was that there was no statistically significant difference between the 2 communities that got the program and the 3rd community that did not. From September through March, which is the 6-month intervention time period, there were actually increases in sugar intake in all 3 communities. But what we found is that in our 2 communities that got the program, the increase wasn't as large. We don't have data to fully explain why sugar increased in all 3 communities, but we have some guesses. One possible explanation is that the intervention happened during the COVID-19 pandemic. They weren't going to school, they were at home all day, and so many of the families may have been under immense amounts of stress. Another big explanation is that there was a store component, and what we found during the course of the program and afterwards was that there was some variation, meaning there were differences in how available these sugar-free drinks were at the stores. We have a program that we can build on. We know that fruit drinks are problematic. We have some preliminary findings showing that, perhaps there is a way that we can help families make better and healthier beverage decisions. And our next step is to design broader programs aimed at preventing tooth decay. And that's the type of program that I think will have the biggest impact on communities in terms of helping families alleviate some of the consequences of untreated tooth decay, as well as some of the difficulties that many families we work with have in terms of accessing dental care. And so it's a combination approach of addressing risk factors like added sugar, making sure kids are brushing twice a day with fluoride toothpaste, and making sure that kids get to the dentist regularly. That's the way we're going to prevent tooth decay in Alaska Native communities and other vulnerable communities.
Through studies like ours, we can enhance public health and expand our outreach to communities that are the most difficult to access. By focusing on underserved populations, we hope to make meaningful impact and foster lasting change. Through executive orders, the federal government has cut billions of research dollars from the National Institutes of Health, drastically reducing funding for universities and research groups like ours. What we've shared with you today is just a small part of nearly 2 decades of research involving many dedicated individuals from multiple communities. This documentary was made possible by NIH funding and support from the University of Washington. Without sustained investments in public health research, stories like ours may remain untold, leaving communities on their own to face preventable health challenges.